Hi, health psychology students. We're going to continue to look at pain, and this time we'll look at measurement, behavioral components, and treatments. There are many different ways to categorize pain. One way is by looking at the potential cause of pain. So pain can be categorized as organic or psychogenic. And organic pain would mean that there is some evidence of tissue damage or there's some apparent damage or injury that's occurred. If there's no apparent tissue damage that's present, then it's considered to be psychogenic, which makes it sound like, oh, it's all in your head. That doesn't mean it's not real pain. When someone is experiencing pain, we consider it to be real pain. It might be that we don't know what the physiological cause of that pain is, or if there is a physiological cause that can be identified. Another way to categorize pain is on the duration of pain, how long the person's experienced it. Acute pain is pain that's been going on for less than 6 months or 6 months. Chronic pain is pain that's been going on for more than 6 months. And you see some different definitions of this, but usually the 6-month mark is where it cuts off for acute or chronic pain. There are many different methods for assessing pain. The most common is self-report, and I talked a little bit about that in the previous presentation, but there are other ways to examine pain as well. One is through physiological measures like electromyography to look at muscle tension. And then when people are experiencing pain, you see an increase in heart rate and blood pressure. So sometimes we can look at that too. And this could be helpful for people who are unable to express their pain for whatever reason, if they're not able to verbalize that or to have other kinds of behaviors that would indicate that they're experiencing pain. There are also behavioral measures of pain. If you observe the individual, you might see them. This could include verbal things like moaning, but it could include facial expressions like grimacing. It could include being guarded in their movement or holding on to the area that hurts, showing some protective behavior. So their ambulation and the way they walk might be different. They might be limping, and those could be an indicator of pain. This would be useful if, again, someone is unable to give you a self-report, like a young child, for example, or if someone is unwilling to admit that they're in pain. But the most common pain assessment method is to use self-report, and we've talked about this a little bit. This is that FACES scale. This actually is a copy of a chart that was at my children's pediatrician's office. And I like this one because, first of all, it's also in Spanish, but I like that it says, we care about you. I think that's a nice little addition there. And so if the individual is experiencing pain, you can ask them to choose a face. You could have them rate it on a 1 to 10 scale. There are some more detailed self-report measures as well, like the McGill Pain Questionnaire. And what you see here is a pretty common component of a pain questionnaire. You have the patient indicate where they're experiencing the pain, so the localization of it. And then there are lots of adjectives that you can use to describe the pain. Is it pricking? Is it boring? Is it drilling, stabbing? Sharp, cutting, lacerating, hot, burning, scalding. So you can see there are a lot of different adjectives. For some people, this might be really useful as a way to describe what they're experiencing and to be able to put it into words. For other people, it might be a bit overwhelming because this is a lot of adjectives to have to look through. Well, we talked about the modulation of pain and why there might be times when pain is increased. Pain is a useful indicator that something is wrong. It can teach us what to avoid, but it's also useful when pain is decreased because then we can continue to function. So what are some of the things that increase pain? Well, certain physical conditions increase pain, like the extent of injury. That makes sense. The bigger the injury, the more pain you are likely to have, although that's not always the case. And then activity level can exacerbate pain as well. So someone who has pain and they overdo it with their physical activity, that can increase their experience of pain. But affective conditions, remember that affect means emotion. Affective conditions can also increase pain. So we know that when people are experiencing anxiety, their perception of pain, physical pain, increases as well. And depression, you see the same kind of relationship. People who have more depressed mood also report more physical pain. So if you have two people who have similar types of injuries and one person is dealing with depressed mood and the other is not, the one with depressed mood is likely to report more pain and experience more pain. And then we can also look at cognitive conditions that will increase pain. If people are focusing on the pain, they're really putting their attention on it, that can increase their experience of pain. And then also when people are bored, they tend to have an increased experience of pain. What decreases pain? When we look at physical conditions, one of the most common that we can see is, of course, medication. And we can talk about some other things too, like some other physical yoga or physical therapy, stretching that might decrease pain and other things too. We're not going to focus on that too much here. The affective conditions that can decrease pain, experience less pain, would be things like positive emotions and relaxation. And then cognitive conditions would be distraction and involvement in life. So one of the problems that people with chronic pain can experience is that they can experience even more pain if they're focused on the pain and if they reduce their activity level to the point where they're not really much involved in life anymore. And then they're more focused on the pain. They have a greater experience of pain. So being able to distract oneself from pain, and you saw that in the video in the previous presentation, being more involved in daily life activities that can actually decrease pain. So we're going to take a look at a presentation on chronic pain and some of the issues associated with chronic pain.
I'm a pediatrician and an anesthesiologist, so I put children to sleep for a living. And I'm an academic, so I put audiences to sleep for free. But what I actually mostly do is I manage the pain management service at the Packard Children's Hospital up at Stanford in Palo Alto. And it's from the experience of about 20 or 25 years of doing that I want to bring to you the message this morning that pain is a disease. Now, most of the time you think of pain as a symptom of a disease, and that's true most of the time. It's the symptom of a tumor or an infection or an inflammation or an operation. But about 10% of the time, after the patient has recovered from one of those events, pain persists. It persists for months and oftentimes for years. And when that happens, it is its own disease. And before I tell you about how it is that we think that happens and what we can do about it, I want to show you how it feels for my patients. So imagine, if you will, that I'm stroking your arm with this feather, as I'm stroking my arm right now. Now I want you to imagine that I'm stroking it with this. Please keep your seat. A very different feeling. Now, what does it have to do with chronic pain? Imagine, if you will, these two ideas together. Imagine what your life would be like if I were to stroke it with this feather, but your brain was telling you that this is what you are feeling. And that is the experience of my patients with chronic pain. In fact, imagine something even worse. Imagine I were to stroke your child's arm with this feather, and their brain were telling them that they were feeling this hot torch. That was the experience of my patient Chandler, whom you see in the photograph. As you can see, she's a beautiful young woman. She was 16 years old last year when I met her, and she aspired to be a professional dancer. And during the course of one of her dance rehearsals, she fell on her outstretched arm and sprained her wrist. Now, you would probably imagine, as she did, that a wrist sprain is a trivial event in a person's life. Wrap it in an ace bandage, take some ibuprofen for a week or two, and that's the end of the story. But in Chandler's case, that was the beginning of the story. This is what her arm looked like when she came to my clinic about 3 months after her sprain. You can see that the arm is discolored, purplish in color. It was cadaverically cold to the touch. The muscles were frozen, paralyzed. Dystonic is how we refer to that. The pain had spread from her wrist to her hands, to her fingertips, from her wrist up to her elbow, almost all the way to her shoulder. But the worst part was not the spontaneous pain that was there 24 hours a day. The worst part was that she had allodynia, the medical term for the phenomenon that I just illustrated with the feather and with the torch. The lightest touch of her arm, the touch of a hand, the touch even of a sleeve of a garment as she put it on, caused excruciating, burning pain. How can the nervous system get this so wrong? How can the nervous system misinterpret an innocent sensation like the touch of a hand and turn it into the malevolent sensation of the touch of the flame? Well, you probably imagine that the nervous system in the body is hardwired like your house. In your house, wires run in the wall from the light switch to a junction box in the ceiling, and from the junction box to the light bulb. And when you turn the switch on, the light goes on, and when you turn the switch off, the light goes off. So people imagine the nervous system is just like that. If you hit your thumb with a hammer, these wires in your arm, that of course we call nerves, transmit the information up to the junction box in the spinal cord, where new wires, new nerves, take the information up to the brain, where you become consciously aware that your thumb is now hurt. But the situation, of course, in the human body is far more complicated than that. Instead of it being the case that that junction box in the spinal cord is just simply where one nerve communicates with the next nerve by releasing these little brown packets of chemical information called neurotransmitters in a linear one-on-one fashion, in fact, what happens is the neurotransmitters spill out in 3 dimensions, laterally, vertically, up and down in the spinal cord, and they start interacting with other adjacent cells. These cells, called glial cells, were once thought to be unimportant structural elements of the spinal cord that did nothing more than hold all the important things together like the nerves. But it turns out the glial cells have a vital role in the modulation, amplification, and in the case of pain, the distortion of sensory experiences. These glial cells become activated, their DNA starts to synthesize new proteins which spill out and interact with adjacent nerves, and they start releasing their neurotransmitters. And those neurotransmitters spill out and activate adjacent glial cells, and so on and so forth, until what we have is a positive feedback loop. It's almost as if somebody came into your home and rewired your wall so that the next time you turned on the light switch, the toilet flushed 3 doors down, or your dishwasher went on, or your computer monitor turned off. That's crazy, but that's in fact what happens with chronic pain, and that's why pain becomes its own disease. The nervous system has plasticity. It changes and it morphs in response to stimuli. Well, what do we do about that? What can we do in a case like Chandler's? We treat these patients in a rather crude fashion at this point in time. We treat them with symptom-modifying drugs, painkillers, which are frankly not very effective for this kind of pain. We take nerves that are noisy and active, that should be quiet, and we put them to sleep with local anesthetics. And most importantly, what we do is we use a rigorous and often uncomfortable process of physical therapy and occupational therapy to retrain the nerves in the nervous system to respond normally to the activities and sensory experiences that are part of everyday life. And we support all of that with an intensive psychotherapy program to address the despondency, despair, and depression that always accompanies severe chronic pain. It's successful, as you can see from this video of Chandler, who 2 months after we first met her is now doing a backflip. And I had lunch with her yesterday because she's a college student studying dance at Long Beach here, and she's doing absolutely fantastic. But the future is actually even brighter. The future holds the promise that new drugs will be developed that are not symptom-modifying drugs that simply mask the problem, as we have now, but that will be disease-modifying drugs that will actually go right to the root of the problem and attack those glial cells or those pernicious proteins that the glial cells elaborate that spill over and cause the central nervous system wind-up or plasticity that so is capable of distorting and amplifying the sensory experience that we call pain. So that I have hope that in the future, the prophetic words of George Carlin will be realized, who said, "My philosophy, no pain, no pain." Thank you very much.
So you can see from that video that there's still a lot we don't know about the neuroscience associated with pain, and especially with chronic pain. And we'll take a look at just some of the examples of treatments for different types of pain. We do know that there are behavioral processes associated with pain, and you can apply learning theories to the experience of pain, and especially chronic pain, both classical conditioning and operant conditioning. So let's look at how those concepts can be applied to the experience of pain. In classical conditioning, if you remember Pavlov's experiments with dogs, a formerly neutral stimulus becomes a conditioned stimulus, and it signals the arrival of an unconditioned stimulus. The unconditioned stimulus brings about an unconditioned response. So an example of this is associated with pain is that migraine headaches can lead to there are a lot of effects of migraine headaches, such as dizziness and nausea, and of course, an extremely high level of pain. Now, some people get early symptoms of migraines. They might start to get dizzy, or they experience kind of an aura before the migraine really hits them. That dizziness, which is a mild symptom, or the aura, which is a mild symptom, becomes a conditioned stimulus. It's signaling extreme pain that's to come. And so when people start to experience the aura, or they start to experience the dizziness, they can experience a lot of distress. They become much more distressed. They think, oh no, I'm having a migraine. The migraine is coming. It increases levels of anxiety, increases tension. That can actually lead to even worse migraine symptoms. So that can heighten the perception of pain when it arrives. But you can also look at operant conditioning, those rewards and punishments, and how that can be applied to pain behaviors. Interestingly, pain behaviors can be reinforced, and we don't often think about rewarding pain-related behaviors. Why would anybody do that? And you often don't think that pain would be a rewarding experience, but this is something that can lead to disability and really lead to a lower quality of life for people who have chronic pain. So some examples of that would be an expression of distress. So somebody moans or they talk about their pain, and that can have some positive reinforcing elements associated with it if other people respond with sympathy, for example. Then that could be rewarding. Now, for any of these things, I don't want to imply that people who are experiencing pain know that they're getting rewarded or are doing this intentionally. But it does happen that people talk about their pain and they receive sympathy. Sympathy is added. They're more likely to express distress in the future. Other examples could be some of those pain behaviors like distorted ambulation or posture, somebody who's hunched over if they have back pain, or they're walking really slowly, they're hunched over and walking, they're limping. That can again bring about some different types of rewards. They can gain sympathy. It can also lead to removal of unpleasant things. So it might be that they are told, go lie down, you seem like you're in pain. And so it allows them to escape from situations. Or it might be, oh, you know what, let me do this for you instead. Now they've had tasks removed or subtracted, and that increases the likelihood that they'll continue to show that distorted ambulation or posture. And it's not always even interpersonal, so it doesn't have to be another person who's delivering these rewards. It could be that if they have distorted ambulation or posture, they're holding onto their arm, they don't injure it again. If their lower back hurts and they're walking very slowly, then maybe that does allow them to avoid a sharp pain in their back. And that's avoidance training. They walk slowly, it subtracts their experience of pain or sharp pain. That increases the likelihood or reinforces walking slowly in the future. And that's negative reinforcement. Expressing negative affect is another example of a pain behavior. Again, affect means emotion, and negative here means something like irritability or sadness or anxiety. And expressing those things can get sympathy from others, or it can get others to leave you alone. So you could have things, pleasant things that are added or unpleasant things that are removed. And both of those things can be rewarding. You can have positive reinforcement or negative reinforcement. And then, as I mentioned, avoiding activities. So lying down frequently, staying home from work, refraining from strenuous behavior. All of those things might reduce the likelihood that they will engage in activities that could cause some additional pain, and then that could be reinforcing. And it also allows them to avoid maybe some things that they don't want to do, like if they don't like to go to work, then staying home from work, calling in sick, would be negatively reinforced. So again, these are not necessarily things that the individual wants to have happen or even are aware are happening. But these are what are known as secondary gains. And you can apply this concept of secondary gains to a lot of different types of illnesses, not just pain. It can apply to other illness experiences or illness behaviors as well. But we're happy to be talking about it here because it can really exacerbate the problems that come along with chronic pain. In addition to the pain itself and the suffering that's caused by it and how debilitating it can be, then others, or just through these behaviors, those behaviors that are limiting the person's ability to just engage in a normal lifestyle and get their regular activities of daily living done, those behaviors get in the way of that and reduce their ability to function, which can then reduce overall quality of life. So let's take a look at some treatments for pain. We're not going to go into the medical treatments, but of course there are some surgical treatments for pain that are available. For example, you can fuse vertebrae together, and that can be a treatment for chronic back pain. There are other kinds of surgical treatments for different types of pain. In many cases, surgeries are not completely effective, or they're not effective for all people. So we look for other kinds of treatments for pain, especially chronic pain. Medication is commonly used. People are really worried about using opiates for pain treatment because of the possibility of addiction. But what we've often found is that people are under-medicated, especially while they're in the hospital, and especially children, and especially people in minority populations, racial minorities, and ethnic minorities. And there are different ways that people can be medicated. One could be taking medication on a particular schedule, like every 8 hours or every 4 hours or twice a day, or PRN, which is Latin for pro re nata, which means as needed. So based on the patient's pain report, then they might be administered pain medication if they tell their doctor, tell the nurse. Patient-controlled analgesia means pain relief, is something that's become more popular, allowing the patient to have control over when medication is delivered rather than having to ask for it or being on a particular schedule. And there was initially a fear that people would over-medicate, and it's been found that people in general don't over-medicate when they're in the hospital and they have access to delivery of medications. As far as health psychology is concerned, we're really interested in behavioral and cognitive treatments for pain, and chronic pain is mainly what we're talking about here. Relaxation can be very useful, especially for pain conditions that are exacerbated by muscle tension. And biofeedback is something that can be very useful as well. In biofeedback, there are whatever the selected physiological parameters are. So for tension headache or migraine headache, it might be measuring muscle movement in the scalp. Might be looking at muscle movement in the face if you're just trying to get an overall relaxation response. You might be dealing with heart rate, finger temperature, or hand temperature, something that's examined for things like migraine. And then there are sensors, and you get those measured values that give you feedback about those biological measures. And you can see, is your heart rate going down? Is your heart rate going up? So you get that audio feedback or that audio or visual feedback, and then use relaxation strategies or other types of strategies to change those parameters. And that can be very effective for certain types of pain conditions. Acupuncture is something that's used. It's not exactly clear how acupuncture works, but one way that's been proposed is that acupuncture needles can stimulate large nerve fibers and block the pain stimulus. So it's unclear at this point, but it's something that can be very effective for some people. And this has been tested too, by using real acupuncture needles and then also placebo needles. Placebo needles are kind of like theater swords, where they're hollow and you push them against someone's skin and the needle doesn't actually go into their skin. The needle goes back up into the shaft of the needle. Distraction is a technique that's used for pain management as well, and that works particularly well for mild or moderate pain. If it's really severe pain, distraction doesn't work as well, but it needs to be something that is very engrossing for the individual. So something that they're really likely to get into, be able to concentrate on cognitively. And then similarly, using imagery, and that can be part of a relaxation technique or other types of imagery training, can be useful as well to take the focus off of the pain or to reframe the pain a bit. Some cognitive techniques would be redefining pain by coming up with different kinds of coping statements. So this would be a type of emotion-focused coping, maybe helping to foster more internal locus of control. It hurts, but you're in control of this. Or it might be if the individual is going through a painful treatment for something that they're hopeful will be useful in the end. Think of the benefits of this treatment, even though it's painful, even though you have to go through it. Or if you think about an example of someone doing physical therapy exercises and they might be effortful and painful, think of the benefits that you're getting from it. As I mentioned when we talked about the different parts of the brain involved in pain perception, mindfulness meditation has been used to treat pain, and it can be useful for a number of reasons. Mindfulness itself is really useful for helping people identify the precursors of pain. Part of mindfulness training and part of mindfulness meditation is being aware of the sensations in your body. And if you're not aware of the sensations in your body until your muscles are aching or you're experiencing sharp pain, then it's difficult to notice when you might be getting to a point where things might be painful. So if you're practicing mindfulness meditation and you're doing something like a body scan and you're noticing just what different areas of your body feel like under normal conditions, then you'll be more likely to notice when something is going wrong. So maybe you've been sitting for a long time and you aren't really paying attention to what's going on because you're working on a paper or you're studying or whatever. If you're being mindful, you might notice, oh, my back feels a little bit tight. I should probably get up and move around. If you don't notice that, then you can end up with full-blown back pain, or you can end up with shoulder pain or a headache. And if you can identify the precursors of pain, you can intervene earlier. You can get up and move around before that pain occurs, or if you're experiencing pain and you need to take an anti-inflammatory medication to help stop that earlier, you can do that. Mindfulness also allows people to redirect their attention. In the mindfulness presentation, the mindfulness meditation practice asks you to place your attention on your breath. And if you are practiced at mindfulness and placing your attention where you want it, you can take the attention off of the pain if you need distraction. And then, as I mentioned, there are different parts of the brain that are associated with the physical pain, the localization of pain, where that pain is occurring and how intense it is. And then a different part of the brain associated with the suffering, the emotional pain. And people who practice mindfulness meditation have shown greater control over those areas that are associated with suffering and the emotional pain part. So still experiencing the physical pain, but not experiencing as much anguish about the physical pain or as much suffering. So people often have fear and anxiety about their pain, and mindfulness can help people to reduce those things. Mindfulness is also useful for managing stress. If you don't get caught up in stressful situations, you can appreciate them for what they are. You can allow stress to occur, but not get all caught up in it, not start a vicious cycle. You can actually reduce the level of stress, which is then associated with less pain. And one of the ideas behind mindfulness is being aware of what you're paying attention to in the present moment, being aware of your present moment experience. And for many people with chronic pain, it is important for them to be able to manage their days moment by moment rather than thinking about when is this pain going to end, or if they're feeling good, when am I going to have pain again? How can I keep feeling good? So mindfulness is something that's been shown to be effective for pain management. Let's go back to those pain behaviors and how they can be operantly conditioned with secondary gains. One of the readings that I've posted is for the Mayo Clinic's pain clinic, and it includes a lot of different elements. It includes medication management, it includes physical therapy, but it also includes a lot of psychological components. And one of the things that they do in these pain management clinics is they make sure not to reward pain-related behaviors. And some of that is just ignoring them. So once you get to the facility, the staff don't give you the same kind of sympathy that you might get from other people in your environment, or they might not do things for you and take away those unpleasant things. So you take away those positive reinforcement events and the negative reinforcement events and really ignore the moaning, ignore the grimacing, the protective behavior, the guarded behavior. They also use operant conditioning to reward and positively reinforce behaviors that they want the patients to engage in. So they use physical therapy to help people gain more strength. They do full assessments to see what people are actually capable of. So they're not going to injure themselves more or re-injure themselves, and finding out what they are capable of and then rewarding them for doing those things. And praising the absence of unwanted behaviors. So you didn't complain once during this session, and that's really terrific. Or I haven't seen you grimace lately. That's really wonderful. And helping them to improve their functioning. So take the example of someone who is walking very slowly because they have had experience with back pain and they're worried that if they walk too quickly, they will have sharp pains in their back. So they walk very slowly. In the past, that has been reinforced because it's allowed them to avoid additional back pain. Well, they're not moving very quickly. They're not functioning as well as they could. And if it's identified that they could walk faster, then one of the goals could be to help them walk faster and also walk with an upright posture rather than leaning over. And so praising and supporting their work toward those goals, and then also praising them for the absence of unwanted behavior. So these pain management programs have interesting goals. The goal is to increase their level of functioning and their quality of life. Someone who's experienced chronic pain for a long time has probably become less and less active. They're probably doing fewer and fewer things for themselves. This is not the case for everyone. They might become quite depressed because maybe they've tried a lot of different medications. Maybe they've even tried surgery. So the goal is not to get rid of the pain. The goal is to increase their functioning, their ability to do those activities of daily living, and to increase their quality of life so that they're able to have good relationships. They're able to do things that give them pleasure. And to decrease suffering. So they might still be experiencing pain, but they're not suffering as much as they had in the past. So the goal is really not to eliminate the pain. It's likely that it will be reduced to some extent. If they're able to get people functioning better, then it's likely, especially for things like back pain, that they're going to be having less pain. But even if they experience pain, they still experience pain, helping them to function better, helping them to suffer less.